always on the passenger side. And I have this computer scientist sort of colleagues. They kind of tricked me into doing something for them. They never really share data for us. And I have this wonderful postdoc, Shen Yu, who now is a associate professor now, I think, at Tsinghua. He was trained as an operational research, so OR person. And at that time, we don't know how to analyze, do NLP, natural language processing, how to deal with free text data. And the whole team was waiting for the computer scientists to finish their algorithm and to pull the data. We were waiting, literally waiting for 6 months. And also, even during that period, they wouldn't explain to us how to use their software. They were not very nice to us. So Shen, as an engineer, just said, I'm going to do it myself. So he spent about a couple months, almost a year, to write his own software. Ever since, we do our own NLP, and that was sort of changed my mindset. So that really is literally my pain. I don't have data, I have to beg for data, and not all of my colleagues are willing to facilitate my needs. So then 15 years later, we go from the very beginning of EHR data. I can download any kind of raw data to all the way end to the final project. So I'll give you some of the examples that in terms of the study. But before that, I do really want to thank Tian, Hongyu, and the organizers here for the kind invitation. And I'm really excited, as you can tell, my loud voice sometimes, about the mission of this workshop. So I'm going to do a big sort of overview of what are the challenges, opportunities using EHR for translational research. And I'm going to touch upon 3 aspects of like EHR, to me, like what kind of research that we are excited about in addition to this translation end. So EHR data, even though it's super valuable, the resolution is low, it's very noisy. So we're trying to develop algorithm to improve the resolution, make the data quality better. It's also like has this major issue, transportability. An algorithm developed in one system is not transportable to another, not really only because of distributional shift. Like we did a lot of transfer learning methods for distributional shift, but this is different. We have coding system that's different. You have language that's different. So how can we achieve that automatically? So then I become excited about it because the infrastructure side actually becomes very interesting research. It becomes an algorithm developed, not like I have some students sitting there to do hard coding. I will also talk a little bit about federated collaborative learning, because for most of the EHR research, usually you are not very certain if you just have one study. So usually you do multiple studies, and how can you actually work together to create a network? So I work a lot with different consortiums to build up this called a federated network. We actually have a granted due this Friday. I have to work on that on the flight back, because we are helping the NIH to establish this like aim-ahead consortium to help sort of more resource-poor universities to build up their EHR for research, become like the different nodes of the network. Then we also have to provide algorithms. Like once you build it up, what do you do? So I actually had my slide, about why EHR research is so important, and that's my nightmare. When I remember chairing a session for the NIH about like AI for cancer research, and I asked like real-world evidence, and the answer was so good that it scares me. But fortunately, this one is not so good. So the one on the left is from BART, and the one on the right on GPT. I think the ChatGPT, I use more ChatGPT, so the answers are better. But anyway, if you can just look at the common theme, there are a few things that make EHR data very attractive. One, like from, for example, FDA perspective, it's really real-world data. It represents, right, people who are sick in the health system. They really want to know, in the so-called real-world effect, like evidence, right? It's longitudinal data, so it's temporal data, both from the patient's like disease trajectory and also temporal in terms of like, people who have the condition in early 2000 versus like 2020, they are actually really different. So there are different kind of temporality. But this kind of temporal trend allows us to evaluate many things, and including developing clinical decision support. Of course, you can also do real-world evidence. But I will also mention how you can actually integrate EHR data with many other kinds of data in different ways to address much more sort of exciting kind of question like drug repurposing. Can you predict a chemical structure? What is the potential effect of the drug? What is the potential side effect? That to us, I have to admit, I know zero about biology. I skipped biology even in high school, so I had none. But I really appreciate what Annie said. Like, I have a student who is interested, so I'm willing to be part. That I'm part of the team. I cannot be the main driver, but I'm willing to learn. So we actually worked on like drug repurposing. Can you actually infer the drug effect linking with genetics, protein and different levels of information? And that data integration is much messier, but it's also exciting. How do we do that? So for those who are not familiar with the EHR data, I want to emphasize one key thing about EHR data is that they have two main types of data. One is so-called structured. So if you write a SQL code and pull the data, there's no error unless you make a programming error. So they are structured, like they're tables, pull the data out. There's also free text. That's the most valuable data in the EHR. So not only you see what codes are given, what lab results, prescription, there are justifications. Why do I do that? What symptoms do I see? And you also see, like when you see a side effect, that the doctor actually document whether the side effect is due to the treatment. So you are much more certain that when you see a side, and some kind of reaction, it's actually reaction to the drug, not a natural consequence of the disease itself. So for the unstructured data, of course, given the rise of large language model, people also have huge interest in like a retraining Llama 2. Can you throw that in and make a Llama 2 like do QA for, like mimic what the doctors do? So every one of us are interested. Of course, we're interested as well working with the VA. But to me, like I also don't want to be the slave of the language model trying to figure out how to fine-tune that. We also use language model to generate certain like silver standard label, noisy label for me to train the algorithm that I'm interested in. So that's just, but in general, we treat the like free text data more as sort of a data element. So you can run simpler NLPs to extract certain kind of data. Is there a mention of schizophrenia in the notes? Is a mention of the drug? Sometimes when the drug is so new, you only see in the notes, they are not actually coded. And also, of course, signs and symptoms, you only see in the drug, is in the notes. And also, like even cancer stage, histology, many cancer characteristics, they're only in the notes. So EHR data itself, like just as in terms of all the codes, medications, they're already very rich, and also they're longitudinal. So they encode any condition that the patient have. All medication prescription, procedure, lab measurements. As I mentioned, you also can run NLP, cover all kinds of signs and symptoms, much more detailed information. And then we do have other data types, including imaging. So that's one thing that's very valuable. We not only have image, every image has a report. So like we talked about the pain of not having segmentation. I'm usually driven by my pain. I don't have segmentation. I've been setting up this contract. For 6 months, I haven't finished just to do segmentation because I cannot pull the data out. So I have limited people who can do this for us. But at the same time, my colleague, Junwei Liu, he's an expert in imaging. So trying to see, can I actually link the report? I can extract information with the report, co-training with the two, and basically bypass the segmentation. You have pre-trained model, right? You can transfer learning to do a good job in the segmentation, but just not so sure if it's doing a good job, so I want to augment with the report information. So that's sort of the benefit. And we do link EHR with disease registry. So there's certain outcomes that I work on rheumatoid arthritis. The major outcome is called the disease activity. So disease activity score usually is not routinely collected as part of clinical care. But registry, that's like clinical trial endpoints, basically are not routinely collected. But they have registry, so we're linking registry with the EHR. At the VA, because they're so huge, they also run a lot of clinical trials. So they also link clinical trial data with EHR. So then I can actually do comparative effectiveness, so that we actually have an ongoing project that link the two to basically I feel a little bit more confident to do comparative effectiveness because I have randomized trial linked. We do also have biobank. The VA has, for example, the million variant project. They have a genotype of almost, they recruited the millionth veteran last November. They actually had a celebration. But they already genotype about 750,000 patients, so you can link. And then you can, of course, link. We are publishing, right now it's in revision for Science, basically the first paper looking at the whole GWAS, not sequencing yet. The whole GWAS of PWAS, basically for every SNP, I want to know against every disease phenotype. So give us a lot more, and also VA has a lot of diversity in terms of patient population, so it's very helpful. With EHR data, like how do we actually link to the ultimate goal of helping patient, right? So obvious thing is to do like dynamic risk prediction. You can rewind the data at any point to predict, pretend that this is a clinical visit. Like right now we're working on a project of predicting suicide ideation. So we team, the key PIs are actually psychologists and psychiatrists looking at suicide ideation. And we developed an algorithm to predict the risk of suicide ideation using longitudinal EHR data under different clinical settings. You can be at primary care. The patient has some issues, maybe like depression. They could be at much higher risk compared to the general population. You could also have patients who already have mental disorders, and those are patients that already are in the ED. They're already in the ED because of some condition. So they are already base risk is a lot higher. And then you have inpatient that are already hospitalized. So for each of the clinical settings, we actually have studies that like the next step. What is the next step that we can help you? Because health system cannot help them that much. I'm very excited about this project is because they are actually connecting with a nonprofit organization that help them to give the patient support in a more gentle way, not like relying like hospital to keep them in the hospital, so that's not feasible. So we developed an algorithm. Right now, we're planning a randomized clinical trial in the spring. So we're trying to figure out like how does it make it work. So this is a setting that you actually have to find people to develop the app. So where the team is looking for a group that develop app and go inside the health system. So we did find that general outpatient, the AUC is very high, but the base risk is very low. But if you look at the relative risk, they are more than 10 times. So you will at least flag them, but you're not going to send them to the hospital. So for those patients, it's much more like maybe they need family support, right? We need to think of things that are more sustainable. But if you look at, psych like emergency department, so you can see AUC is already lower because they are more similar, right? So how do you help them? So these are the patients actually we're trying to see what can we do for them to run trials. So as I mentioned, we also link with genomic data. And one kind of study that we did is to look for particular variants that there is like functional variants. So for example, this is a PWAS study that I did with my colleague, Catherine Liao. She's a rheumatologist. I worked with her for like 15 years. We look at this particular variant is IL6R. And this variant corresponds to the drug of tocilizumab. Basically, the tocilizumab was developed to target this gene to inhibit the production of CRP, the inflammation marker. So CRP inflammation is super important for rheumatoid arthritis. So they use it for tocilizumab, but tocilizumab is used actually for many autoimmune diseases, for example. So this one, we are actually curious about the potential alternative indications of the drug. So we look at the genetic variant and run a so-called PWAS. Basically, look at every single disease condition we're searching for and see what other effect does it have. So we did pick up, at the time of our publication, we did find that there are other studies that identify tocilizumab has a protective effect of cardiovascular conditions. So here we see a bunch of different cardiovascular conditions, including aneurysm. We did also find the drug side effect. It's like a skin irritation. And you can find it in the original trial. That's one of the indication, like a side effect of the drug. As I mentioned, you can link EHR data with many other data types. But because I have a really painful situation that I can never share EHR data outside of the system. So what we have been doing is that we derive a lot of summary level data. So we hear many people talk about, embeddings, et cetera, right? We actually created embeddings using the EHR data. So each of the EHR concept is represented by a finite dimensional embedding vector. That I can transport out. Now I have that, sorry. How do I go back? So now I have that, I can link with all kinds of data. So we treat this like a knowledge graph, a link prediction problem. So I can bring foreign entities into this. So for example, we looked at chemical structure of a drug. They may or may not actually already have a drug developed on the market. You imagine that drug companies, right? You are in initial stage. You still only have the chemical structure, and then you have, some protein functions, et cetera. So we linked our EHR embeddings with the FDA. Also have a list of drugs, the chemical structures, et cetera, and document what are the indications, what are the side effects. So once you link the two kind of data sources, we actually benefit from the relationship between different diseases and drug and the phenotype that we observed in the EHR to make this a much more powerful analysis. So we were able to predict for example, the indication of the chemical structure. You can also segment your training data into by time, right? You can look at the drugs developed up to 2020. The drugs appear after 2020 should not be in your training data. So you can look across year to see does it do a good job. Recently, my postdoc, he's also interested in studying the effect of missense variant. So some of you probably saw a paper published by DeepMind earlier last year, alpha missense. So they are trying to predict whether a missense variant is pathogenic. So there are actually many papers on that. Alpha missense did very well because it was actually unsupervised training. And but so far in the literature, they only know whether a missense variant is pathogenic, does not know what does it do. What disease does it cause? So we are part of this undiagnosed disease network. Harvard Medical School is sort of the data coordinating center. So we work with many of the institutions. They have actual patients who have undiagnosed disease. And what we did in this study, basically, we were actually trying to predict what is the likely plausible condition. We rank order the top condition that can this particular variant predict. So we validate using the UDN, which is not in our training. Right now, we are actually setting up the final analysis, I hope, that we identified one of those patients that we predicted, and the UDN has not yet diagnosed them. They prioritized the variant, so that means that they have some idea. But prioritize is not perfect, and they don't just prioritize one, right? So we were able to predict, and we're trying to go back to the clinician and say, do you think that's a plausible condition? And we also validated that there are certain conditions, even though they are causal variants, but you can actually diagnose the disease relatively easily using lab tests. They're almost perfect. So in other words, I have other mechanisms to diagnose the disease, and we can use that as a gold standard, right? I can look back. Then we can also tell the UDN people, these should be the causal variant. So they already diagnosed it, but they don't know for sure which one. So we also use that to diagnose. But I have to admit, again, my lack of biology training, this is as much I can talk about. Don't ask me any more questions about the biology side. But I find it fascinating. And for that, I'm very happy to be the team member to just listen, to learn from the clinicians. We have a clinical, he's a geneticist and cardiologist. So we are super happy team together. So this is one of the studies I'm most proud of. This is a study that we did, I would say by now, it's almost 3 years ago. FDA reached out to us. I team up with this person, Florence. She's a clinician. She's also the co-director of the Harvard-MIT Center for Regulatory Science. So FDA at that time had a congressional hearing coming up about a particular device, so EVAR. It's for endovascular aneurysm repair. So the EVAR there's this company that Effects. They have different iterations. The first 2 iterations already pulled off the market because of the side effect. So the Effects 2 was already the 3rd generation. They're supposed to already fix the problem. But there's some signal saying that they might still have a higher side effect compared to the traditional devices in the market. But FDA is a little worried. Don't know for sure. So they reached out to us. They wanted us to do this study with them. Basically, they contracted us to do the study to understand whether or not this particular device really has a higher risk of this particular endpoint called a type 3 endoleak. And basically, they start bleeding at the whatever site. And the type 3 endoleak is not coded at all. It's only in the notes. And this is also challenging because there's a lot of negation. Because FDA already started worrying about it, so all the clinicians will document, no, the patient does not have type 3 endoleak. So basically, you really need NOP to do well to capture it. But this is a study we went really from the very beginning, they just have a question. And then we went from building the database to all the way to the end to generate a report for the FDA right before their congressional hearing. But that was really scary because that's a part of if I messed up, I'll be so scared. I'll probably lose my tenure in that case. But this is a very interesting study. If you look at we only have the endpoint up to year 5 because that's the last follow-up. So basically, the new device, type 3, the FX2 was only on the market up to that time. But if you look at so this is we did, double robust causal modeling, et cetera. So this is, if you look at the event rate, and this is the side effect, the difference of the event rate. The difference. So what you can see here, here. So if you can see from here is that the orange one is the one that's, the one on the right is mortality. The one on the left is the type 3 endoleak. The orange one is the one that you should be looking for. The one totally flat is the non-effects based on your reference. They start to seem to suggest over time they're going up. So because of that, FDA actually at that time basically gave them a warning. They didn't pull off the market, but they say they're potentially has. They don't know for sure. So they suggest to basically don't use it unless you have to. But they are not pulling. So this is one of the studies I really want to go back. Now I have 7 years of follow-up. I wanted to see, do you actually see more uptick? So of course, given all these potential, right, there's a lot of hype about how you can leverage EHR data, but there's a lot of problems in the EHR. First of all, it's very noisy. So codes, they are optimized for billing. So that's why people love Epic, because they make more money for the hospital, but it's a terrible EHR system to use for research. But they still use it. There's a huge miscoding. For example, at the Brigham, among patients who have at least 3 ICD code for rheumatoid arthritis diagnostic code, only 58% of them actually have RA. So that's terrible in terms of misclassification. And also in the old days, I went to a study with clinicians, we talk about what you want, and that's a very bad practice because even if they give you a list of features, one, they may be subjective, right? If you ask another clinician, they might want another set of features. And second, you have to then manually map what they say into a variable that you want. That's too manual a process. So that's sort of one of the pains. That's why we develop knowledge graph. We go from the raw EHR data instead of going from the clinician. I show them, here's the feature. Tell me which one if there's more you want, I can add. But usually it's comprehensive enough. So we almost can bypass clinician for the manual checking of the feature. But as I mentioned, there's transportability issue. There's also health system bias. Like VA, for example, predominantly male, which will not allow us to study much of the information about female. There's also, other biases like Mass-Brigham, MGB is like a tertiary hospital, so they tend to treat a much sicker patient, et cetera. So that will give us some potential susceptibility to unreliable or generalizability. So I'm going to touch upon all 3 points, like how can we actually improve data quality, improve the transportability and generalizability from like algorithm or methodology perspective. So to increase the resolution, we do a lot of so-called EHR phenotyping. So basically, it's like some kind of algorithm that instead of using a code to define yes, no, or at a given moment, yes, no, we use an algorithm to predict, become a classification problem. This is a more or less like a standard, if it's a classification, right? We've done classification for decades. So I'm just like briefly list of what things that people are doing. There's a rule-based, of course, that's not very generalizable sometimes. There's supervised, semi-supervised. So those all require human curation of the label that require them to do chart review. We still do that to a certain degree because I need to validate. But otherwise, it's labor intensive, so it's not scalable. You cannot do like 100 or 1,000 phenotype. People have also done a lot of so-called self-supervised or weakly supervised. So you can think of like ICD code. It's imperfect, but it's good enough. It's a noisy version. So you have to think about like what assumption are we making when you say noisy label? What kind of misclassification or error that's in it that justifies that I can train a model using that as an imperfect outcome? So there's a lot of interesting algorithms or both statistical and machine learning people have developed algorithms, and also we do use a lot of clinical notes. So obviously attaching the large language model is very useful for information retrieval. I want to focus more on the second part, and my biggest pain point is the data itself, quality. So, and also transportability. So the transportability, as I mentioned, if it's just a distributional shift, there's many tools. I'm not even going to do any review. Many of you here develop awesome methods. I'm talking about a different issue. There's a heterogeneity in coding. So far, these consortiums that I'm talking about, we actually still do it manually because they don't have the capacity to set up the system. So if you want to study CRP, for example, you actually have to go to each of the hospital to figure out what is the code. They're all different. And then basically, if you don't know that, you can't even do the study. You need to figure out what is the base code that you need to use to represent this particular feature. So I want to talk about the kind of work that I've been doing in the last at least 5-10 years, like thinking from the sort of methodology or algorithm perspective. So when I first went to the VA, we were already working on it. And I told the VA, hey, I have this fancy algorithm. I'm going to automatically assign your local lab. So their lab codes are all like not organized, majority not organized. So basically, every hospital, VA has 1,200 like clinics. So every clinic can be sending their lab test to a particular laboratory to process it. They come back as a local code. So they have 400,000 lab code. At Mass General, about 2,000 after they map to common ontology. At BI, we have a very experienced informatics person. They only have 200. So in other words, the majority of the labs that are done in the US, you should be in the magnitude of a few hundred to like 2,000, not 400,000, right? How can we help VA, this kind of system, to really automate? Can you have like a smarter Google search? A search, like you come to the website, you search in CRP. At least if they pop up, you can say, these are the things I want. So that's what our goal is. To basically, I cannot perfectly map them, but I can do a smarter search. How do we do that? So that is done mainly through so-called representation learning. Like as Xiao mentioned, most of these are like some kind of dimension reduction. They can be nonlinear dimension reduction. It doesn't have to be linear. But as a statistical problem, I find it really fascinating. So I did one of the papers with Xu Shi. She's now assistant professor at Michigan. Oh yeah, that's the only paper I ever got some kind of award. I still have $333. Xu did a wonderful job, but she just kind enough shared the award. Peter helped us to get the award. I'm gonna donate my money to take the kids out to like a bar. So the basic question is, I have two sets of codes across the two health system. Some of them have dictionary that's mapped. Can I turn it into a statistical problem to say you are predicting, basically for future codes that are not mapped, tell me which one I should go. So how do we turn into the data, right? But if you have like a representation, so basically you embed, you create this semantic embedding for each of the code, you have a vector that becomes the data for the code, then becomes a regression or classification problem, right? The reason that paper was fascinating to me was that our dictionary is imperfect. Because the manual mapping, none of them is perfect. So there's distortion. Basically, you have like misaligned data, but we assume a small percentage of misalignment. Like, can you create a method to justify why it's supposed to work? So basically, if you write into a statistical framework, you have, Y1 to Yn is from one system. That, again, each of the is a vector of embeddings, and X1 to Xn. What you are trying to learn is this, whoops, what did I do? Whoops, I don't know why. But so basically, the W here is so-called the translation matrix, and the pi here is the mapping matrix. You are trying to learn both of them. And one thing I find really interesting in this kind of like us thinking about a statistician is that most of the existing work is doing this kind of one-to-one mapping, but it's never one-to-one. For example, we do like ICD-9 to ICD-10 mapping. ICD-10 is much finer. So the number of codes are not like, they're naturally not one-to-one. And sometimes you need a bunch of codes to represent a bunch of codes over there. So that's sort of one of the main things that they did. But basically from a statistical problem, it's a corrupted regression problem. Like you have some corruption in the system. You can also think of this as a link prediction problem, as a knowledge graph. So the embedding, like a lot of the machine learning literature, they call this like a knowledge graph embedding. So basically you see like a graph, but the back end of the data is embedding. So if you think of that, this just like you have a bunch of nodes, you become like graph alignment, right? Or link prediction, like which of the two nodes are like synonyms. That's one kind of link that I want to predict. And then once I can detect that, I'm going to just connect all of them. So that's sort of the interesting part. And here, by the way, I just learned from Haoda yesterday, which website to actually use to create AI-generated graph. I decided to use Firefly. I uploaded, I just wanted a cartoon to be fun. So basically, just imagine that in this case, I have 3 health systems. UPMC is a University of Pittsburgh Medical Center. I have a long-term collaborator, so he shipped his data to our server. I have data from the VA, I have data from Mass General Brigham, so I have 3 health systems. They have different nodes, and I'm trying to link them. But also, my end goal is not to just map them. If I can join to represent them, their representation, talk to each other, then it's actually much easier later to do transfer learning, because they're all embedded in the same space. So we did, for this particular project, usually our team work, like we solve the problem first. Like I don't actually view myself as a statistician. I just want to solve the problem. So for this project, we actually used a lot of graphical neural network. And it does do better. It does have a lot more flexibility. We also use a lot of GPT to generate like silver standard labels. If I have 2 codes, I can ask, can you tell me what's the long description? Because sometimes it's an acronym. Like your own algorithm doesn't do well to learn like WBC, white blood cell count. But if you ask GPT, it will tell you it's supposed to be white blood cell count. So we first ask it to expand it, and then we have initial algorithm to say these are the top 5, and we ask GPT which one is more accurate. So we did find, by the way, GPT-4 is a lot more accurate, but it costs me more money, so I have to ask them to watch how much money I spend. But they count by token. Yeah. So, but it was very helpful because it generated many links for us to train the GNN. And in the end, basically, we also, one thing I want to say that these codes, like initially when we trained the algorithm in the previous round, we only look at how the codes are used in the EHR. So I'm heavily relying on sort of the clinical representation of the code. But there's an orthogonal information is the description of the code, the words. That we never used. So then we use a pre-trained language model to embed the words, and what we found is that they're very complementary to each other. They're not the same in terms of their strengths and benefits. So we actually do use both sources of information to understand what does it do. And in the end, basically the final product is that I'm able to embed all codes across all health systems. And once we set it up, we are now talking to our potential customers. Hey, this is, I have 3 nodes. You want to be one of the node? Then they'll be willing to create the summary level data that we need. And then they will be part of the node. And then we will refresh our algorithm. But once you have the embedding, you can really do a lot with the data. So here I just want to show you one sort of the case study. We just look at a lab. VA has a lot of lab code, and we did the mapping to the loin code is a common ontology. So here our algorithm is the one on the bottom, and I just want to show you that is purely unsupervised. We did not use any human annotation, although we did use GPT, so I wouldn't say it would be weakly supervised, but we can do as well as a supervised, so we can bypass any of the human annotation. The last point I want to make is how can we unlock the data value through federated collaborative learning? So we treat each of the node in the network as really, they contribute unique information. But there's, of course, heterogeneity, right? Not only the patient population, their outcome model, for example, may not be the same as my outcome model. And particularly, how treatment is used in the cross system are very different because they have insurance. They have different insurance types. VA doesn't have insurance problem. So they have a particular way of requiring how medications are given. And of course, the privacy constraint. I cannot share individual level data. So I just want to point out at a high level, what kind of things are interesting. So again, we are very good at, if you just think about all the current federated learning algorithms that we have developed in the statistical community, most of them basically think about, there's some kind of shared structure. You need to have something shared, right, so you can learn from each other. But you do allow for certain kind of heterogeneity. You can say, part of the coefficients are similar, part of them are not. There's also a lot of emphasis in improved efficiency, how much communication. Oh, that's very important. Apparently, Michael Jordan gave another very fascinating talk. He said it's really, at the end of the day, it's economics. What's their motivation, right? Again, I learned in a hard way. I have to have my research associates started talking about life with their research associate. Hey, what music do you want? They have to be friends in order to run it for you. It's painful for them to do this over time, right? So in other words, communication is important because there's human value in it. There's also a lot of work, like, for example, Hongzhe, and I know many of you guys also work on like differential privacy, right? But to me, like if I have to pay such a high price for the distortion of the the end product, basically there's a sacrifice, right? You add noise to it. The signal is already so weak. You add noise, I can't do anything. So to me, I'm not interested in that. But I'm interested because I'm willing to trust my server on HMS. So they are willing to share summary level data with me on HMS. So then it's okay. I just need the summary level data. I don't need differential privacy. So that's just my personal sort of desire, just because our signals are weak. We have a lot of interest in the improved robustness in terms of, just imagine that you want to train a model that's useful for a future target population. May not be one of them, right? So there has been a lot of work in recent years and like so-called distributional robust optimization. Basically, they wanted to make sure that in the future target population, if it's a mixture of your current source population, it cannot do very poorly. So they have this kind of minimax or max-min kind of concept. We have also been doing some work on consensus learning. So sometimes, this is an interesting story. We have this consortium for COVID. We started in March of 2020. We work with many institutions from like 8 countries, many different sites. There's one site from Italy. Oh, their data is so bad. So in the end, you look at it, it's just so off. You always kick out. Pen is another example. I'm not going to say which one. A chop, yes. I was going to not say chop, but it's really chop. Every time we look at it, it's so off that I have to take it out. But it's manual. So we're also interested, can you actually automatically kick it out? So there's this sort of consensus learning. Basically, it's almost like post-selection inference, right? You have to use the data to determine, and what if it's sort of on the boundary? Then the inference become a non-regular, because you have to pay the price. So how can you do a proper inference to account for this kind of inference? So I do work, for example, with Zhi Jianguo a lot on this, because he's an expert in the theory part. We have this strong motivation to say this is what we really need to achieve. And last thing I want to touch upon is the dissemination. So one, I do have a huge desire to just train the algorithm using summary level data, because I can convince my friends. I actually also often take them to lunch, have a social time to gently convince them, but they'll be willing to share summary level data. So if your algorithm is really trainable on, this is our web API, this is Shiny. So they upload it, they click a button, they train the algorithm. Then they're willing to do it. Actually, many clinicians are very excited about it, because they also think about their friends. They can group them into our network. So we develop a lot of the APIs that actually allow people to train this algorithm. And as I mentioned yesterday also to Susan, we actually work with a nonprofit organization. They do the last mile for us. They even create a automated video with instruction. I just do need to give them the text. And they create a video. It was awesome. So for each of the app that we develop for VA actually loves it. So VA now gives a contract to the nonprofit, and they go from the beginning to end, including this kind of video with instruction. So that's the last mile I think we really need. It's very important, but it's not necessarily research, right? So I outsource for them to do that for us. So just to wrap up, I think there's a lot of potential in using EHR data to do sort of reliable and explainable AI. I still like the model and to understand the model, but I don't usually badmouth just to say, oh, you have a black box. If they have a black box that's much better than mine, I have no say. But if we have similar performance, then explainable is very good. I'm very passionate about improving the EHR quality, and also I feel like the data access issue we talked about, I feel like we should do something. I almost feel like it's a democratizing AI research, right? Because otherwise, they don't. For other people who want to enter, it's just too long of a process. And also, there are a bit different methods to improve, for example, overcome the bias in the house system, and to mitigate this so-called hallucination. That's where sort of explainable is helpful. So we also create a lot of knowledge graph. So instead of using random features, we actually tell you what features might be useful. So sort of using the knowledge graph to guide it. But the last point that I want to talk about, data science, much of it, I believe that it's science of the data itself. Like you need to understand the data, both from how it's generated so that you can talk to the informatics database people, to how to interpret, you can talk to the clinical side. But I think one thing I really wish that our students have more is curiosity. You don't have to know it, but you should be curious enough to listen to other people. And eventually, when you listen enough, you can be more on the equal footing to talk to them. So that'll be it. Thank you.
I think when we take questions, we can get the next speaker. I think Joe, your next.
Tianxi, just comment. So very early on, I worked with MD, and he just tell me, say, look, these days, so we have, every hospital have a different EHR system. He say, he actually is burdened by EHR. He say, well, in the old days, it's very simple. He spent more time with the patient, but these days, he spend a lot more time with the EHR than with the real patients. Then his question for me is, as a statistician, say, can you, let's say, provide some tool, maybe even a table, a figure, or illustration, one page that you can quickly summarize over the, because otherwise he said he doesn't remember over the, he said, really, I think this is something that's very useful for the MD.
So, very good question. That's my ongoing project. So we want to work with the VA to actually develop a search. I want to know what's going on with this patient. I can allow the physician to say rheumatoid arthritis. If you just click link to the EHR, it should do a summary for you. What are the key medication? When do they start? What other comorbidities you have? We actually developed the first prototype already, and we're trying to work with the VA to see. The one great thing about the VA, they care a lot about the veterans. They also want the best care for them, and that's like I asked a few clinicians, what is the thing that you want the most at this moment, given AI tools? That's when there was someone from the National Academy of Medicine to give a keynote speech. She talked about AI. She talked about data is the future oil. Like it's such a good commodity. But I think we actually, as a clinician, they have exactly the same thing. I don't have time to sort through so much information and to figure out how do I figure out which code, right? So yes, we are trying to see. Based on knowledge graph, it's actually very easy because you know what you should be looking for if you say what you want. Because sometimes the patient has too much information.
Thank you. So we don't have much time, but we have lunch and break and afternoon discussions. So we